Patients are going to demand from primary care physicians that they're able to make specific diagnoses when they twist their ankle or twist their knee or hurt their shoulder. Simply calling something a sprained knee or twisted knee or bursitis of the shoulder is not going to be adequate. The physician needs to have the physical exam skills to be able to distinguish specific diagnoses of musculoskeletal injuries. Let me make a few general comments regarding the musculoskeletal examination. First of all, the approach to the patient is very important. I always try to start with the uninjured extremity to give the patient a sense of comfort and a sense of what it is you're doing. So I'll do some of the exam techniques on the uninjured extremity first. And then there are at least 5 components of the exam that I would suggest you do. And I would suggest you do them the same way each time, and that way you won't miss something. Specifically, start with inspection, looking for asymmetry, atrophy, swelling, or ecchymosis. Second of all, do active range of motion, and specifically what you're trying to do there is ask the patient to do as much as they can with the injured extremity because you want to see what they're willing to do. That way when you go and put your hands on them and start to manipulate, you at least know what their limitation is and what they're ready to do. You don't want to push them too far past that. Okay. Once you see what range of motion they're capable of, then you want to try to have them do that against resistance. You want to test their strength. Fourth, you want to do passive range of motion. You want to be able to see within a certain relative pain-free range, what are you able to test for? Are they grossly lax or are they just a little bit lax? And finally, you want to do functional testing. You want to see on their own, weight bearing, for instance, for an injury to the ankle or knee, are they able to walk? Are they able to raise up on their toes? Are they able to hop? Potentially, are they able to run? Inspection, active range of motion, resisted range of motion, passive range of motion, and then functional testing. This video is going to focus in on the ankle, the knee, the back, and the shoulder. And the focus is going to be diagnosis using physical examination skills. Let me take a look at you and see how you're doing. Okay, let me start briefly with some surface anatomy of the ankle. As you're going to start your examination with inspection, most ankle injuries are inversion injuries. This is a model of the right ankle. Inversion would involve turning the ankle under that way. You're most likely in the beginning to have swelling on the lateral part of the ankle because that's where the ligaments that are likely to be torn are. And specifically, I want you to look at the anterior talofibular ligament. That's the most common ligament to be torn in an inversion injury. Then there's the calcaneofibular ligament, which is the second most common ligament to be torn. And finally, in a distinct minority of ankle sprains, you tear all 3, anterior talofib, calcaneofib, and then posterior talofib. When you tear all 3 ligaments, you are likely to, and it won't allow this in the model, but you completely dislocate the ankle, i.e. the talus, out of the mortise. You dislocate the ankle completely. You're bound to get swelling immediately with even routine ankle sprains. When you do your physical examination, always palpate the proximal fibula because even though you have an inversion injury of the ankle, and a lot of your pain here is what brings the patient to the clinic or the emergency room, they may actually have, in some minority of cases, an avulsion fracture of the fibula. You have to palpate the fibula. I palpate the whole distal fibula, lateral malleolus. I palpate the medial malleolus. I palpate across the anterior ankle, trying to palpate specifically over the lateral dome of the talus, which is sometimes palpable, and then the medial dome, which is sometimes palpable. I will then palpate over the base of the 5th metatarsal, because in routine inversion ankle injuries, you can actually have, as the principal injury, not so much ankle ligamentous tear, but you can fracture the base of the 5th metatarsal. An important anatomic point is that the peroneus brevis tendon comes down and inserts right here at the base of the 5th. So if you have an inversion injury here, you may actually avulse a piece of the base of the 5th metatarsal off. That's why to do a complete ankle examination, you have to palpate the base of the 5th metatarsal. Let's just suppose you see them relatively soon after the injury. Make sure that you try to distinguish tenderness from point tenderness. Let's suppose, for example, if you have a fracture of the distal fibula, they will be not tender, not tender, tender, not tender, not tender. The point being, if you have a lot of swelling, you're going to be diffusely tender everywhere you touch. But if you're fractured, you would like to find on physical examination that you have discrete point tenderness, whereas proximal and distal to that, you don't have tenderness. Now, the patient who comes into the emergency room or into your clinic 4 hours or 6 hours or 24 hours after the injury and who has diffuse swelling, the physical exam is not going to be very telling in that regard because everything is going to be tender. The key that you want to emphasize is, do they have neurovascular integrity, i.e., do they have good perfusion? Can you feel pulses? They have intact sensation and some motor activity. In addition, you want to see if they can possibly bear weight. If they can bear weight, the more they can bear weight pain-free, the less likely they are to have a fracture. And then to the extent that you can, you want to try to palpate the discrete bones that you're able to palpate. If you feel crepitus, they have a fracture until proven otherwise. Eversion injuries, where the foot turns out, you are more likely to get a fracture of the talus, medial or lateral dome, as well as the lateral malleolus or medial malleolus, but you can get an injury here to the tibiofibular syndesmosis, where you tear this ligamentous joint here. And the way one can appreciate that on physical exam is to squeeze the lower leg together. Sometimes will worsen the pain, but sometimes even more so when you leave it go. The patient will complain of remarkable pain up in here. So that's one physical exam technique that I think is appropriate. When we have the patient go through active range of motion, we have them go through plantar flexion. This is dorsiflexion. And what we ask the patient to do is plantar flex and invert, plantar flex and evert. And when they're everting, specifically, you want to hold the lower leg so that they don't rotate out their whole lower leg. You want to just see as much eversion at the ankle as you can, and you don't want them rotating the leg or the hip. Dorsiflexion and inversion, dorsiflexion and eversion. So those are the 6 basic maneuvers that you want to do. Have them do it actively, and have them do it against resistance. You just provide resistance against each of those maneuvers. You want to hold the resistance for 3 or 4 seconds so they give a good force against you, because some people may be able to give you a second and then boom, they'll break. You want to see, can they sustain the contraction. Okay, press inside, go. Okay, up here again, right here, press. All right, and right here, go. All right, good. If you want to do passive range of motion, you want to be able to see within a certain relative pain-free range, what are you able to test for? Are they grossly lax, or are they just a little bit lax? It is important when you're making your assessment to see whether or not the patient can bear weight pain-free, or with how much pain they have when they try to bear weight. Patients with mild to moderate ankle sprains can bear weight, and if they can bear weight relatively pain-free, then have them try to go up on their toes. The more they can bear weight pain-free, the less likely they are to have a fracture. There is another functional test that we do. We don't always do this the first time we evaluate them, but we see that it's more important in follow-up. Patient starts to improve, their swelling's going down, their pain's going down, their range of motion is improving. We'll ask them to try to hop on the injured ankle and compare that to hopping on the uninjured ankle, specifically how high they go, how much balance they have. One thing I like to do when I see patients, maybe on the initial visit, but certainly on follow-up visits, is to inspect from behind and see what their calf muscles look like, because a patient that has been doing their rehabilitation will have good tone and good bulk of their gastrocnemius muscle. The ankle that's been injured, you'll see less definition, less tone, and in fact the muscle will be smaller. Until you rehabilitate that to get them looking symmetric, the patient's not going to be able to return to their activities of daily living. One other test that we think is real important is being able to test for dorsiflexion by having the patient lean against the wall and see what their active dorsiflexion is. The inability to dorsiflex and push off when they walk results at the end of the day them having tenderness and swelling and pain, which means long term they're probably going to have some problems with that ankle.